Just my objection to the introduction of CTOs has actually got nothing to do with whether they work or not, as I'll come to during my talk. Now, while they have obvious implications for psychiatric patients and professionals, I think it's important to see CTOs as part of a wider cultural trend towards the micromanagement of risk. They can be seen as the mental health equivalent of the precautionary principle of a better safe than sorry approach to life and risk. But I think in addition to that, the debate over CTOs is instructive in what it tells us about governmental attitudes to the public and to liberty. So, as many of you will be aware, CTOs came about mainly due to the perception that care in the community had failed. It was a laudable but ill-conceived policy that had put the public at risk from patients and the patients at risk from themselves. And some high-profile tragedies where ex-patients had killed were reported in the media, and you had government spokespeople issuing statements, voicing concern and arguing that something needed to be done. Now, the perception of danger far outweighed the reality, but nevertheless, one outcome of this was a renewed focus on the issue of CTOs, which it was held would help ensure patients' compliance with medication post-discharge, and this, in turn, would reduce the rates of homicide and suicide amongst the mentally ill. Now, whilst a commendable goal, as Tony has alluded to, there's little evidence that CTOs would help achieve this. Risk assessment in psychiatry is certainly not guesswork, but it's far from an exact science. In 1999, the National Confidential Inquiry into homicides and suicides by the mentally ill claimed that CTOs would prevent only 30 suicides and two homicides per year. By 2006, the same NCI was now admitting that actually no reliable way of calculating how many would be prevented. They just didn't know. This issue of preventability, however, leads us to the obvious question of how many people do you need to detain and or place on a CTO to make sure you prevent 1, 2 or more deaths? Well, one study estimated that 100 people would need to be detained to prevent 1 suicide, whilst 5,000 would need to be detained to prevent 1 homicide. The problem, though, is much wider than this, is linked to this wider culture of fear and risk aversion. And in this respect, while it was argued that CTOs would be used selectively, only in a very small proportion of patients, it was obvious to anybody with any nous that they would be overused. So, whilst there was initial estimate by the great and the good that between 300 and 450 CTOs would be issued in the first year that professionals could issue them, after only 6 months, over 2,000 people had been placed on one. Now, and the figures have continued to rise year on year. Now, you don't need to be a natural cynic to surmise that perhaps people are being placed on a CTO not for their benefit, not for the benefit of the patient, but for the benefit of the professionals, to cover their backs in case something does go wrong. Now, mental health professionals are acutely aware of the cultural climate in which they are operating. Having said that, it certainly is the case that mental health professionals have more than a duty to their patients. They also do have a public protection role. But this leads to my second point regarding how CTOs were justified, that there was a need to quell public outrage, public anger over the danger that community care had exposed them to. And therefore, the government, and indeed mental health professionals, had to act to alleviate public disquiet. This is an argument you hear over and over again. I've lost count of the number of times I've heard this argument. You hear it from politicians, you hear it from academics, you hear it from many mental health professionals. There's only one problem with it. It isn't true. There certainly was a media panic and sensationalist headlines over the dangers posed by ex-patients, particularly in the wake of cases such as Christopher Clunas, who killed Jonathan Zito at Finsbury Park Tube Station in the early 90s. And there was also certainly some well-organised campaign groups, such as the Zito Trust, was set up by Jane Zito, whose husband Jonathan was the person killed by Clunas. And the result of all this was that the issue of community care was brought to the forefront of the political agenda. However, contrary to popular opinion, there was no public outcry. Where were the marches in Parliament? Where was the mass picketing of the Royal College of Psychiatrists? Where were the mass public protests? There weren't any. The idea that there was is a creation of the political and media establishment and also some mental health professionals. In actual fact, attitudes to the mentally ill remained pretty positive in the period before, during and after the 2007 reforms, despite, I would argue, the best attempts of the media and politicians to inflame the issue. And public attitudes have continued to show overall improvement over the course of the last 20 or so years. You could argue that the general public has a much higher opinion of psychiatric patients than the politicians, than the media and some mental health professionals. Now, the outcome of all this, though, has been the breaking down of the barriers between hospital and community treatment. And now many people see little difference between the mentally ill being subject to involuntary treatment in hospital and in the community. For them, there's no contradiction. The hospital wall is, after all, only an arbitrary line between inpatient and outpatient. Well, this may be the case, but it's problematic for two main reasons. First, for a free society, such barriers between the public and private spheres are essential. But increasingly, we're witnessing the steady encroachment of public bodies into the private lives of citizens. And I would argue CTOs are but one example of this wider cultural trend. Second, whereas psychiatric intervention against the wishes of the person can be justified at the point of hospital admission, even from a libertarian standpoint, if you don't believe me, you need to reread Mill's On Liberty. This does not necessarily apply at discharge. On admission, the patient may be in an acutely psychotic state, having lost touch with reality. However, at the time of discharge, this is rarely the case. At discharge, the patient can be well, have full mental capacity, with greatly reduced psychotic symptoms, or even none at all. Prior to the introduction of CTOs, it was acknowledged that at this point, the now ex-patient regained the rights of citizenship that the rest of us take for granted. And that includes the right to refuse medical treatment, even if professionals deem it to be in our best interests. Today, subject to a CTO, the patient does not return to full citizenship status, but to reduced social standing. Neither full citizen nor patient, but a diminished hybrid of the two, the community patient. So in summary, the argument over the effectiveness or otherwise of CTOs is an important one, but it misses the most significant ethical and political point, that those subject to them do not want to be. And if we want a free society, we need to respect that decision. Just slightly in response to something Simon said, I'm not against the Mental Health Act. I worked as an approved social worker for many years and was involved in sectioning quite a few people. So I'm sort of certainly of the mind that there are times when the legislation has to be used for people who are clearly unwell and require hospital admission and treatment. What I'm against is this extension of hospital treatment into the community. Because although the Mental Health Act is not capacity-based, it's risk-based, I think capacity and autonomy are crucial here. And we can have people who have been discharged from hospital who can be very, very well, as I said, with no psychotic symptoms at all. And I think at that time, if there have been decisions made to discharge them from hospital because they're well enough, that should give them the status of full citizen, not this diminished hybrid of the two, the community patient. And what someone said as well about it makes the job easier because resources are stretched. And sort of at the acute level of psychiatry, resources are terribly sort of stretched. It's absolutely awful at times. But that's a political issue. You know? And I sort of take Tony says it makes his job much easier and it makes the psychiatric nurse's job much easier in their day-to-day work. But there's people on the other end of these. You know, there's people being subject to things, one, that don't work, and two, that diminishes their status. And I think for those reasons, that's why I'm against them. I'm not against the Mental Health Act per se.
If I start with Ken and then Simon and then Tony.
The point at the front, it goes that there's usually most clauses, of some legal expert will probably correct me for the crudity been crude. I think it's around unsound mind. If you're deemed to have unsound mind, then you can be sort of treated against your will in most countries' mental health legislation. It's like this idea about forcing people to take their medication, or putting them in CTOs and then getting recalled, and it's been seen as beneficial. I still maintain that once somebody, if they're deemed to have capacity, they're deemed well enough to be in the community, they should be deemed well enough to make their own decisions, and that includes whether to take medication. Now, psychiatric medication is not Smarties you're getting. Now, this is very, very powerful drugs that these people are getting, and it carries severe side effects. In fact, whenever I speak to some ex-patients, they shout at me when I mention side effects. They actually say that's a way for the likes of myself, Tony and Simon to minimise the effects. They say if they're happening to you, they're effects of the drug. There might be unintended consequences, but they're effects. They're very, very real. So I think we sort of need to turn to this. If we're deeming them to have autonomy, we should be deeming them well enough to refuse that medication. If somebody gets ill again, professionals can go in and section them if necessary. But I think if a decision's made that they can be in the community, they should return to full citizenship status. That's my key point.
Well, of course we do deem the vast majority of people with mental disorders to have autonomy. Last year, 960,000, sorry, 1 million, I'm going to round up. 1 million people have been treated by our secondary mental health services. That's not including everyone treated outside them, the 4 million people in general practice and so on and so forth, 1 million. Of those, 20,000 are subject to some form of mental health act and 4,000 are subject to CTOs. So the vast majority of people with mental disorders have full autonomy, are in the community, make all the decisions, even when we disagree with them. And even when we disagree with them, we have to accept that, just as we do with other disorders. But all civilized societies always accept there's a small number, and it is a small number, for who don't have autonomy and who don't have capacity. And that's what the mental illness, it's complicated because we have a Capacity Act as well. But basically, fundamentally, those are the people who are clearly ill under any system. It doesn't matter what, and diagnosis isn't the issue. These are very easy to diagnose. I mean, for once, psychiatrists, even psychiatrists are in agreement about that. It's about how you treat them that's difficult, but diagnosis is rarely an issue. We agree that it is what a humane society does, is treat people in order to improve their health. The purpose is not to prevent suicide, it's not to prevent homicide either, by the way. We're not very good at that. But we are quite good at helping some people to get back to health, and that's what mental health acts are for. And, but on this particular bit of the Act, the CTO bit, it's a simple, for me, I have no problems with treating people in the community under a CTO if it could be shown it keeps people out of hospital, which is the least restrictive option. I don't want people to go to hospital if we can do it better in the community, but it would appear that we can't.
Ken.
The functional mental illnesses are not diseases. If anything, the best we've got is they're a constellation or cluster of symptoms that we give a label, such as schizophrenia or bipolar to. In terms of what's required, I do think there is a sort of real gap in services, for crisis centres, for example, therapeutic communities, supported housing, residential homes, nursing homes for those that require it. But that's fine. What we're talking about here, we're talking about people who don't want your help. It's very easy to help people that want your help. It's not so easy to help people. You ask, I would do often, as a mental health professional, I'd say, and sort of, what do you want? And say, to be honest, Ken, I want you to F off out my life. That's what I want, but, that wasn't going to happen for a variety of reasons. But what my point is, they should have that right to say that. Until they reach the level of compulsory admission to hospital, they should have the right to tell me. The question about if they've been shown to be effective, would I still object to them? The answer to that is yes. Now, for me, it's sort of missing the point of the debate. For me, the issue here is about, does somebody have capacity? And even though the Mental Health Act trumps the Mental Capacity Act, I think the issue of capacity is crucial for sort of people to be citizens, to be classed as full citizens. Now, capacity generally is for a specific issue at a specific time. So generally nobody has lacks capacity to decide in everything. You may be deemed to have the capacity to decide to get married, because you don't actually need much capacity to decide to get married, but not the capacity to take out a car loan, for example. These can be real examples. But it's for a specific issue at a specific time. What we're seeing with CTOs is that people who can have no psychotic symptomatology coming out of hospital and deemed to lack capacity to refuse their medication for up to 6 months, which can then be renewed and could be renewed forever, I suppose, eventually. So that is why I think it's crucial if we support autonomy and full citizenship for people who have capacity, we should object to CTOs. And that's where I think it's really important sometimes not to get bogged down too much in the technicalities of CTOs, because what we're witnessing is this wider cultural trend towards the precautionary principle, the micromanagement of risk, the micromanagement of society, a better safe than sorry approach, and increasingly the encroachment of public bodies into the private lives of citizens. And I would maintain that when somebody leaves hospital, they should be classed as a citizen.
Thank you, Ken.